So it looks like we have a quorum. So Donna, any reason that we wouldn't go ahead and get started? Okay,
Go right ahead.
groovy. Well, welcome everyone. And really grateful that everyone's able to join us here today. We have a few announcements at the front of the meeting. And so first is that unfortunately, Aman has been called away today, so she will not be able to join us. And Justin has also been called away today, so he will not be able to join us. And we have, let's see, I don't see Lindsay quite yet, but Dan is stepping away for just a short period of time. And so I believe that Lindsay will be stepping into that space, Lindsay Hopper, and carrying Dan forward as we have a little bit of grace for him. And so next, although it pains me to turn it over to you, Eric, I'm going to turn the mic over to you, and you have something that you'd like to share with us as well. And it is wonderful to see you today, by the way. Well,
it's good to be back. It's good to be back on my feet, and it's good to be back here. So thanks for letting me horn in at the front end of the meeting. It's good to see all your faces. I wanted you to know that I'm making some changes, and some may already understand that, but I will be retiring out of as president and CEO of Partners in Care as of March 31st. And so I think this also means I'll be retiring out of the board seat here on the Health Council. So I wanted to do this in person. I appreciate being a part of this, and I am really going to miss all you folks a lot. I think this is an organization that is doing, it's certainly been near to my heart, and it's something that's working on behalf of the health and the health care of this region. So I've also been appreciative of being kind of holding up the banner of end of life care on the board and being part of that wider community of interest of the Health Council. Going to miss serving with all of you. I've always been amazed at the caliber of the talent on the Health Council board, but as important, the caliber of the talent in the leadership of Donna and this incredibly wider team of support that makes the Health Council work. So thanks to all of you. I wish you my best in the vision that you continue to hold for this. I'll be watching and looking for your successes as you go forward. So thanks very much, and fair winds and following seas to all of you.
Well, Eric, the gratitude goes back to you as well. Thank you for your investment of time and passion, the work that you've done on the governance committee and policy work, and helping us really strengthen some of the foundational components of us as a board and an entity. And just for your wise counsel and sort of calm presence in the storm of things that sometimes perk up. You've just offered incredible knowledge and wisdom that is going to carry us forward. So please don't be a stranger. Know that you're always welcome. We'll save a seat and a lunch, and look forward to the next chapter for you. And just want you to know how grateful we are for your leadership in helping us to be where we are today.
Well, thank you for your kind words, and best wishes to each of you.
Thank you. So let's see. So thank you, Eric. We will go back to the public comment, and I think Donna, maybe we'll do introductions really quickly, or that work for you? Okay, great. So I'll go ahead and I'll do my Brady Bunch boxes here. So I'm gonna turn it over to Renee Worth. Renee, would you take us forward?
Hi everyone, Renee Worth, she, her, and hers, and I'm a project manager with Central Oregon Health Council.
Excellent. Michaela.
Hello everyone, I'm also a project manager with the Central Oregon Health Council, and my pronouns are she, her, and hers.
Wonderful. Camille.
I'm Camille Smith at the Central Oregon Health Council. I am also using she, her, and hers.
Excellent. Gwen.
Gwen Jones, project she, her.
Okay. Rick.
I'm Rick Trelevin, clinical social worker and director of Best Care Treatment Services.
Excellent. Paul.
Hi there, Paul Andrews, Superintendent, High Desert Education Service District.
Wonderful. Trisha.
Hello, everyone. Trisha Wilder, the Director for Central Oregon for the CCO, Pacific Source, and I use she, her, and her pronouns.
Excellent. Gary.
Good afternoon, Gary Allen, Vice President of Clinical Services, Advantage Dental.
Wonderful. Megan.
Megan Hayes, CEO of Mosaic Medical and Safety Net Clinics.
Excellent. Brad.
Hi, folks. Brad Porterfield, Consumer Rep, Chair of the Community Advisory Council, and also with Latino Community Association.
Wonderful. Thank you. Rebecca.
Hi, everyone. Rebecca Berry, Grants and Metrics Manager here at the Central Oregon Health Council. I use she, her, hers pronouns.
Wonderful. Erin.
Hello, everyone. I'm Erin Fair Taylor, and I'm the Vice President of Medicaid Programs here at Pacific Source. And I also use she, her pronouns.
Excellent. In the bright sunshine, Divya.
Hi, Divya Sharma. I'm an internist, chief medical officer for both Central Oregon Independent Practice Association and the Pine Community Health Center, and she, her pronoun.
Wonderful. Patty.
Patty Adair, Deschutes County Commissioner, and it is really sunny out there.
Yes, it's beautiful. Linda. Oops.
Wrong button. Linda Johnson, community member on the Health Council and chair of the Governance Committee. She, her, and hers.
Wonderful. And my partner in crime, Leslie.
Hi, Leslie Neugebauer, Senior Director of Medicaid Governance at Pacific Source.
Wonderful. Kristen.
Hello, Kristen Tobias, Community Health Coordinator at Pacific Source.
Okay, and Miss Donna Mills.
Yes, good afternoon, everybody. Donna Mills, currently serving as the Executive Director for Central Oregon Health Council, and my pronouns are she, her, and hers.
Wonderful. And I'm Tammy Bainey, your tour guide for today. I'm the Executive Director at COIC and Chair. So next we have public comment, and I don't see individuals that are from the general public, but most of our partners here. Anyone have anything that they'd like to bring forward? Okay. Next, we have the acceptance of the agenda and the consent agenda. Any changes to today's agenda or the consent agenda? And if not, I would welcome a motion.
So moved.
Thank you, Rick. And I think I saw Linda going for it, but not quite off mute.
Second.
Wonderful. Okay. Any further discussion? All right. How about anyone opposed? Okay, so that's the acceptance that everyone is in favor, and we will move on to the one of the best parts of our meetings, and that is the patient story. So Brad, I'm going to turn it over to you.
Hey, actually, Linda Johnson's going to share the story this time around. So
All
Linda.
righty.
And I'm having some bandwidth problems, so let me know if people can't hear or if I get bumped out. This is a little bit of a lengthy one, but I think it's important for us to hear the quality and the emotions involved in this story. This is
Linda, we may need Linda, we may need to go off video.
The patient story that I want to share is
Linda, we may need to go off video. It's really garbled on.
first time I had to navigate our healthcare system while on the Oregon. Is there something I need to do? Do I stop recording or does Camille have that?
I think actually if you take yourself off video, that might help.
No. Okay. Is that better?
Yes, much.
Not so much.
No, it's better on our end. Yes.
Okay.
Yep.
I will start over. Okay, good. The patient story I want to share is about the first time I had to navigate our healthcare system while on the Oregon Health Plan. I've always had private insurance until I had my first daughter, and everything was smooth sailing until my daughter started preschool. Once my daughter started preschool, she started to get sick more than normal, even more than a typical kid just starting school. I had to schedule her an appointment with Clinic A because each time she got sick, it was worse than the time before. And it always ended up in her lungs. So having asthma myself, I was concerned that she too had asthma. My initial conversation with Clinic A was frustrating and discouraging. I called for an appointment and was told my insurance only covered one well child check. The tone of the conversation changed from bubbly and helpful to annoyed and belittling. I still remember it all these years later. I still pushed for an appointment because I had a health concern for my daughter. And the person making the appointment told me I should just call the nurse hotline with concerns when they happened and gave me information. I explained I would be calling a lot. I think my daughter has asthma. I want her to be seen. So they finally gave me an appointment for 3 weeks later with the nurse. My daughter would need to see a nurse first before a doctor, I was told. Between the time I called Clinic A and her appointment, my daughter was in the ER because she had difficulties breathing and a temperature of 105. The scary part was how quickly her breathing worsened in the middle of the night. After 5 hours in the ER and telling the doctor, I think my daughter has asthma, I was told to seek care with a new provider or to talk to my daughter's primary care practitioner. At the time, my daughter's PCP had retired from Clinic A, and we were establishing care with a new provider at Clinic A who she had seen before school started. My daughter was released once her oxygen levels stabilized. She was prescribed antibiotics and a nebulizer after an x-ray showed she had pneumonia. The next morning, I called Clinic A back and asked to switch my daughter's appointment from a nurse to an appointment with the doctor. I was given the same script and they reluctantly got her scheduled a few days later with the same doctor she saw before school started. Once we were at the appointment, I explained to the doctor our family history of asthma and the recent health complications, how the nebulizer resolved her symptoms and the ER visit asthma and how bad this was affecting her quality of life. I was told by the doctor that my insurance would not pay for treatment until my daughter had a certain number of incidences proving she needed treatment for asthma. I was dumbfounded. After the antibiotics and the nebulizer treatments, my daughter was back to her healthy self. I use the nebulizer as needed for asthma symptoms. I'm familiar with asthma, so I do know the signs. I had also received a phone call from vendor A saying I needed to return the machine to them because the prescription was up. I asked how to call my daughter's doctor's office and left a message. Eventually, my call was returned, and I was told that my daughter doesn't have a medical need for the nebulizer and to return the machine. I again expressed my concerns about asthma, and the nebulizer resolved her symptoms. And I asked, what if she can't breathe again? What do I do if I have nothing to help her? They told me to take her to the ER. I refused to return the nebulizer and continued to use it. My daughter didn't get until I ran out of albuterol for the machine. And of course, my daughter got sick. Her symptoms worsened quickly and I rushed her to the ER again. I again explained everything, especially after being ridiculed by the ER doctor about my daughter's health and them telling me because of her slow response to treatment and depleted oxygen levels. My mom, who was a paramedic most of my life growing up, told me to request the respiratory specialist that was on call while at the ER, so I did, and the ER doctor agreed to page them. While waiting for the specialist, the nurse taking care of my daughter pulled me aside and apologized for how our healthcare system works while on Oregon Health Plan, then snuck me a handful of albuterol for the nebulizer. Yes, the one I was holding captive. I know this was illegal, and I know that can be very dangerous, but I am familiar with how to distribute medication properly and made that clear when I spoke with the ER doctor. The nurse witnessed the conversation between the doctor and me. When the the specialist got to my daughter's ER room some hours reluctant behavior and spent they want insurance company or other way to code or to talk to OHP when the patient has severe asthma complications like my daughter's. They told me when I called Clinic A what to say and how to word it so that I would get an appointment quicker. They also asked a personal call them. My daughter was eventually released from the ER after about 6 hours. I called a new doctor, one who was more familiar with asthma. I was able to get an appointment immediately. I think it helped. There was a note from the ER specialist on my daughter's file before I called. The specialist called right before me like they said they would. Clinic A had already reserved this for my visit. It's obvious your daughter has asthma, and it's just to hear these words. I can't change what is her say that the new doctor put in a new prescription for the nebulizer and a refill of albuterol, along with an inhaler. She referred us to a respiratory specialist, and we also scheduled another appointment with her 2 weeks later to see how she was responding to medication. This doctor was my kid's PCP until they retired. There's a lot more to this story, but for time, I summed it up the best I could. What I didn't mention is how my daughter cried when she thought that I was going to give back the nebulizer, or the times she cried when we ran out of medicine. No one, especially a child, should ever have to experience that feeling of running out of medication. I didn't mention how she would break the blood vessels in her face and eyes from coughing so hard, or how lethargic she looked on a regular basis. I also didn't mention that I had another daughter who was 2 at the time, and she missed me. I was so exhausted from working full-time, caring for a sick kid, and trying to advocate for my sick daughter to fully be present for my youngest at that time. I was also going through a separation during all of this and didn't have a lot of support from their dad. I would often have to tend to my youngest while talking to providers, and she would have to go to the ER until I could get a hold of my mom to come pick her up. I remember the horrible feeling trying to rush my oldest daughter to the ER and carrying her, while my youngest cried for me because she was tired and scared late at night walking into the ER. I pleaded with her to please walk with me, and I would hold her soon. The amount of stress that this situation caused has probably shaved a few years off my life, as well as impacted our family in a lot of ways. The reason I chose this story to share with you all is because the flaws in our healthcare system, while on OHP, have continued to repeat themselves through the years. The only difference is I knew what to say and how to say it to get appointments and to be taken seriously when issues arose. Through the years, I have shared my experiences with friends and family members to help educate on what felt like and train them on how to navigate through our healthcare system while on OHP. My oldest daughter at the time was 4, and she is now 12. She's not had an ER visit for asthma complications in almost 7 years. This is because her asthma is well managed and preventive care is amazing. That means she is seen when issues arise, so her medications can be adjusted before her symptoms get worse. I had access to a specialist who further educated me on asthma. We were and are a team that cares for my daughter, and that was possible because of OHP. My concerns are with our healthcare system and the patients on OHP that are not able to advocate or press the issue of quality care like I was able to. I am concerned about the amount of people who have suffered because of flaws in the system and who are still suffering. I would like to see more support for our providers and staff in the form of education on health disparities. Additionally, I want their voice to be heard about the issues they experience while trying to treat people on OHP. I cannot fathom any other way to fix a flawed system except working together to resolve the issues. If there are any follow-up questions, I am happy to answer them. Thank you for listening.
Wow. Even with some of the garbling, it was an incredibly powerful, not just story, but experience. And, having had personal experience of pneumonia twice, of not being able to feel like you can breathe, I can't imagine what that young child must have felt like, and the mom of feeling helpless in doing her best. Any comments from the board in terms of things that you can lift from this lesson or that you hear that particularly speak out to you?
I think for me, it's just another example of how our healthcare system isn't really built for patients. It's built for the system. And so that's just something that, you know, needs to be cracked, but it's very complicated to do that because of all the various contributors to it being designed for itself versus truly for patients. Even in the most patient-centered environments, caregivers and doctors and physicians will do their best to work through the system to do everything they can for patients, but the system is still really challenged to be able to do that easily and seamlessly.
Excellent point, Megan. Brad, do you have comments? I see that you're off mute.
Yeah, thanks, Tammy. I was just trying to gather my thoughts back after listening to Megan. Yeah, I think a couple things that I hear in this story that I've heard, you know, multiple times over the years from clients and so forth is families is how, you know, I mean, it is a system of people and people have our faults, right? But the fact that when you let somebody know that you have Oregon Health Plan as your insurance and you can see their demeanor change, or you feel like you're treated differently once you shared that information. I've just heard that many times, that people get that sense. And then one of the other things is, being able to advocate for yourself. There are so many people who are not able to advocate for themselves. And that's, there's many reasons for that, but just having the self-confidence, number one, having the information you need, number two, having, interacting with somebody who's responsive and listens well and kind of helps you in the medical environment, medical care environment is another one. And that just came out loud and clear. It's like once Stacy shared, got that experience under her belt, then all of a sudden she knew, what are the right words to use? What are the right kind of phrasings to use? What are the right times and places to push a little harder? And, it's just too bad that it has to be that way. But anything we can do to make it less that way would be fantastic.
Agreed. Anyone else? Well, please share our gratitude for the gift of the sharing of that experience. And I think it would be good, I'm not sure, Donna, if maybe we could send the letter out so that the board could have an opportunity to read through it again. There was a bit of a garbling there. And not to make light of the situation at all, but we are working on a broadband needs assessment. And so, Linda, we're going to be, yes, and thank you to Deschutes County. So we're going to be working to expand broadband. So, the example of, imagine if we were trying to go through a course online or try to have telemedicine. We tend to think that broadband isn't around for many, but it's areas really, really close to Bend even. So, Donna, do you mind sending the story out? That would be fabulous. Thank you.
Got it.
Okay, groovy. All right. Well, thank you, Brad. And next, I'm going to turn it over to Erin with Pacific Source.
Sure. So I think I'm sharing a bit about some recent news that our executive team here, Dan and Lindsay and Ken and others, made a decision to waive any potential recapture because of the ongoing experience of the pandemic and the impact that that's had on all of our communities and our providers. We know that we're not entirely in control of costs and utilization, and we're not operating optimally because of all of the challenges that that's presented. And so as I'm still relatively new to Pacific Source, being 7 months in, but it's my understanding that they also opted to waive the recapture should there be one for 2020 claims experience. And so they've also chosen to follow suit and also waive the recapture for 2021 experience. So we are still completing year end. We've got some claims lag and provider risk experience still to play out. So we don't have an exact number, but we have estimated. I'm pulling up my number here. We have, I'm sorry, I didn't realize I was next on the agenda to have this at my fingertips and ready to go. We have an estimated recapture for 2021 at a little over $4.1 million. So if this were not waived, that would be sort of the estimated recapture amount for 2021 experience. And again, that is subject to change based on, you know, how things continue to play out as claims information and experience continues to flow through. But wanted to share that news with you. And so that is one less thing for us to kind of worry about, so to speak, as we're thinking about what our experience was collectively in 2021. So with that, I'll pause and entertain any questions that folks have.
I will just start with, this is a wee bit of a mic drop moment. And for being 7 months in, you get to carry some pretty incredible news to the board. And I often get asked, how is the relationship with Pacific Source to your board? And how is the partnership in that community? And I just want to underscore the importance of what this means. It really is in light of that commitment to community and that commitment to this relationship. And Donna and I have had an opportunity to, to thank the team and thank Ken for that leadership and commitment to us in the work that we are doing. So really just wanted to say, this is that mic drop moment of excitement that the conversation would be very different if we were passing the hat right now for 4.1 million.
Yeah.
So.
Yeah. Well, it's yes, it is really an honor to be able to share this with you. It's not always that I'm the bearer of such great news. But, you know, as you said, we're in this together. This is about the community. This is about how we meet the community's needs. And we felt like this was the best way, you know, as it relates to this piece of our work together to really demonstrate our commitment to the community and hopefully help us all collectively overcome some of the challenges that the pandemic has presented going forward.
Thank you so much, Erin.
Yeah.
Yes, that is incredible news and super exciting to kick the year off knowing that we're strong as ever. So really excited about that. So before we go on to the next agenda item, I wanted to welcome Rebecca and Kat. And the next agenda item is Linda. And Linda, it did work fairly well to have you off screen. So do you want to give it a whirl again and give us an update on the governance committee members, please?
Sure. I even washed my hair for the meeting, so I'm bomb. So I'll keep it brief because of the garbling. There were two topics that we wanted to talk about. One is that with Eric leaving and Tammy, who's now chair of the board, leaving, we have two vacancies on the committee. The committee talked about two things. One is the expectation that every board member be a member of at least one committee. And most of us, but not all of us, fill that bill. And secondly, we discussed the possibility of appointing someone perhaps who's not on the council, but that would be someone with an outside expertise, perhaps in governance issues. And so we wanted just to open that up and see if the board had any concerns or any thoughts about that.
The crowd's going wild, of course.
Yes. So I'm assuming no news is good news. So we will continue that discussion next month as a committee and decide on where we want to go with it. The second topic is the RHIP alignment survey. And for this, I'm going to go ahead and turn it over to Gwen and is it
Rebecca.
Rebecca? Sorry.
Oh, all good.
Thank you, Linda. Okay, so finally, we're here. We have the results from this long survey that you all suffered through, and we learned a lot from. This might look quite different if we choose to do it again. So just a little grounding in this survey. So in the strategic plan for the board of directors, demonstrating effective governance is one of the strategic directions. And one of the qualities of effective governance is the actual utilization and actualization of the regional health improvement plan. The RIP, as we affectionately call it, is created to collectively align our community's shared priorities. And when your organization adopts and actively advances a priority or measure, then all of our communities are impacted. So we can't do this in a silo. If we have more organizations signing on to improve various priorities within the health improvement plan, we have greater collective impact. So this survey was a baseline measure of our current alignment between the organizations represented on the board of directors and the priorities within the regional health improvement plan. And so of our 15 board members, there are 13 organizations that are represented. And so on the alignment with priorities area, you'll see in the top left there, the number of organizations reporting alignment to each RIP priority area. So I know that's a little bit small. Hopefully, Michaela, I'm so sorry to ask you to make that larger. Thank you. That's helpful. So you can see each of the 6 priority areas that are in the regional health improvement plan. So addressing poverty and enhancing self-sufficiency. We have 7 organizations aligning with that priority area. Behavioral health has 10, physical health has 9, stable housing and supports has 4, substance and alcohol misuse prevention and treatment has 5, and upstream prevention has 6. And then over on the right there, the number of organizations reporting at least 3 RIP alignment with at least 3 RIP priority areas is 62%. So just over 2/3 of our organizations, or just under 2/3 of our organizations, align with half of the priority areas in the regional health improvement plan. And actually 100% of our organizations have alignment with at least 1 priority area, which is fantastic. Gwen, I'll hand it over to you.
Thanks. So scrolling down, nice job. You landed in the right spot. So what we did next was look at alignment and participation between the work groups and organizations, knowing that when it's alignment also correlates to working together. The RIP work groups are just one area where that can happen, but that's one area that we can look at within our scope. And so we did that. And so we did our own internal audit, and what you see on the left here is the number of organizations with a regular participation in a RIP work group. And we define regular participation in our terminology as 50% participation or attendance and participation in a work group. So you can kind of see the range there on that graph, where stable housing has a couple of organizations from the board sitting and participating in the work group. And then on the opposite direction, we've got physical health, substance and alcohol misuse, and upstream have about 6 folks or 6 different board organizations participating in the work groups. And then shifting to the right, when we do a high level kind of summary, the number of board organizations with at least 1 regular participant on at least 1 RIP work group is 85%. So really large participation overall. And then scrolling down, if you would, and you'll have to zoom out. Oh, that's perfect. What we did next was look at, do a comparison between priority area alignment as reported by those completing the survey and work group participation, seeing what do these look like when we put them together? How do they correlate? And so you can see that some organizations reported alignment. There's some work groups had organizations reporting alignment, but lesser participation, and vice versa. So it was pretty a broad variety when you're comparing those two across the work groups. Go ahead and scroll down one more time. So some of the considerations that we found, that last paragraph is really the summary of those data considerations. What we found was that there's a large variation between organizations' reported alignment and participation in the work groups. And what we found was that an organization might participate in a work group but not report alignment to the priority area, or they might report alignment with the priority area but not have participation. So it didn't necessarily go one way or the other. It was very mixed. So that was the data considerations. Some of the learning points of gathering this data, as you've heard before, was that the alignment during the survey and gathering what alignment meant for those first set of questions was interpreted by the reader to mean alignment with the organizational strategic plan and organizational activities. There was some conversation on that and interpretation needs. And then and of course that reporting is dependent on an individual's position and knowledge within that organization, and that from experience and some analysis, there was some variation in that as well. So happy to answer any content questions. Rebecca and I can answer any content questions around the graphs, and then we'll hand it back to Linda for the conversation of, so what now?
Gwen, I'm curious, have we looked at this before to see the trend of the participation and the alignment?
We haven't looked at them together before. No, this is the first time.
Having looked at the data, a little bit more and having time to digest, what are your observations?
I think the comparison is really my observation. It's like, and what does this mean? And I think wrestling with it, I'm gonna pass it right back to you, Megan. I think there's a lot of work happening throughout the community. I know when we as staff are looking at how are all the different pieces of the Health Council connected, we're trying to draw those threads thicker and tighter, so there's more linkage for that collaborative purpose, and because there's so many lines of business, if you will, but they impact each other so much. And so this is one of those ways that we're trying to find that connection and build that connection. And it's really the first time we've really looked at it this way, even as staff. So.
I know that one of the things that came up at the committee is the original purpose of this was, when we think about big picture, integrating community and public health with traditional medical provider structure. By integrating those, we have probably the greatest potential for improving the community metrics on health. And right now they're sort of in separate silos. And so the question is this the right measure? Is there another measure that would be more appropriate to look at to measure alignment around the same objectives? What does alignment really mean? Does it mean it's included in your strategic plan and you're actively working in a particular area? Or is there some other metric we should be looking at to sort of pull us towards the goal we want to have?
You know, it's been a long time since the survey was done. But as I recall, trying to interpret alignment and interpreting it, you know, exactly that it had to be aligned with the strategic plan and organizational activities seemed kind of limited to align with both, because you know you could be actively engaged, and I think there's differences in how organizations view strategic plans. Some are pretty broad, and you know, I couldn't really point to things in the strategic plan that said there was alignment, but I could certainly point to organizational activities that would be more in alignment. So maybe it's just my limitation of understanding, you know, what alignment really meant.
One of the things that makes me kind of go back to when we had these conversations about how we can bring these to our own strategic plans many, many, many years ago. And I think the hypothesis is if there is alignment, whatever that's defined as, and engagement, that the areas of focus and the metrics will continue to advance in a positive way. And so I don't know if there's a way to interrelate, you know, how we measure alignment or engagement to the impact it has on our outcomes in the different categories, because that's kind of the why behind this alignment. And I think that regional health assessment, the other reason that that was so beneficial is so many organizations have to do health assessments, and having one health assessment for the region that all our entities can use really also that supported alignment. So I don't know if there's a way to interrelate that to see if it's having the intended impact, but that might be another thing to consider.
Rick, dive in.
So I think what we encountered is the problems with a lot of surveys, and I am reminded suddenly of a survey class I took at U of O psych department. And I believe there were dinosaurs that roamed the earth at the time, but how laborious the process is you have to go through to get a valid survey, and it isn't just to write stuff. And every time I've tried to write a, you know, even a client satisfaction survey, I run into the same set of problems and get reminded of the same professor in the same class. And so we toss around an idea of alignment, and we all think, okay, that makes sense. And to operationalize what alignment actually means across widely divergent organizations and organizational structures turns out to be more of a detail-y problem than not. But I think the core principle that Megan outlined is, are we aligned as a healthcare community around particular goals or not? And does that help us achieve those goals or not? I think is still a worthy thing to try to tease out. So I don't know, my sense is it may be worth sorting that out some more, or maybe you all just Gwen and Rebecca just say, oh, enough of this. This is unsolvable. But I think the principles that Megan was outlining are correct.
Great point. So Gwen, Rebecca, what else would you like from the board? Have we given you a bit more to chew on? Do you want to bring this back?
I think Rebecca, tell me what you're thinking, but my initial thoughts are governance has taken the impact, and I know staff are happy to dive in deeper and figure out what's next, because, you know, we love big gnarly things. So happy to do that if that's the direction that you all want us to take. So we'll defer. Rebecca.
I will add one caveat. Thank you, Gwen. As we continue to be in a pandemic, our data is also being impacted. So a number of sources that we use for the Regional Health Improvement Plan, as well as the broadening sources that we utilize and track continuously for our regional health assessment, are delayed in a lot of cases. And so in a normal environment, Megan, I think we could probably have something to you. I just do not foresee it being very accurate or meaningful with our delayed data that we're struggling with. And that's something I can imagine we'll see ripple effects from for a few years, unfortunately, particularly school level data, graduation rates, third grade reading, kindergarten readiness, things like that. We're having a hard time getting that data right now.
So Rebecca, when do you need to start doing data gathering for the next regional health assessment? How many years out is that?
Yeah, so we'll start. It's going to look different this year. I'll start with that. So it won't be a 300-page document. It will be our Central Oregon Health data site, and the actual physical document will be a highlight of particular data points that either are looking really good, trending really well in one direction, or are becoming more and more concerning as we're seeing those trends. And so we'll have access to that data site with all of that information. And then we'll take that information and highlight or bring to the surface the things that we really want to draw people's attention to. We'll also be adding in qualitative data through continuous survey collection throughout the entire region. And so that will actually we'll start collecting that survey data next month, and that will be continuously collected moving forward. And so we'll start the regional health assessment process at the end of this year. And we will.
So I would just comment that many organizations are at a stage of rebuilding their infrastructures. I've certainly have spent the last month or two into very deep dives into our back office functions. In my own organization, my observation about Oregon Health Plan is 2 years of working from home has been a disaster for them. And it's just places that seem virtually to the point of collapse. And so I just worry about the capacity and the validity of the data that you are able to draw from. And I don't have a acute solution for that. So.
Rick, you bring up an excellent point. It occurs to me that we've all been changed somehow by the COVID, and I don't think we even know enough yet to know how we've changed, but it sort of calls to question the assumptions that we made and what we thought we knew about what it took to make process improvement or to improve health outcomes may be different. And so at some point, I think we need to review that and test what is it post-COVID that still exists and what is it that may have changed. Because at the end of the day, without that discussion, I get concerned about how we will be able to recognize tangible improvements in the healthcare of the community.
Well, you know, there's some really basic pieces in behavioral health. Steve Allen, who's Director of Behavioral Health at OHA, presented before the legislature earlier this week about how half the residential capacity in the state for behavioral health services has disappeared in the last 2 years. just devastating, and how that has consequences all over the system. You know, to state hospital utilization, to, you know, locally, we have people out on the street who have no business being out on the street. So you start getting these systems things, and that's just a little piece. I'm sure there's worse stories elsewhere, but those are challenging times, and how we wrap our heads around that, I'm not really sure.
Another head scratcher might be that it's also at a time where we've had the most significant investment, where it's just sort of a head scratcher for me.
Right. If we have a health improvement plan, and yes, we've had COVID, but with all the resources and alignment of organizations and the work we do around this table, if they haven't resulted in improvement of health of the community, what do we do at that point? How do we create a process of identifying and testing what will work to move the meter? So it's an enjoyable time to be on governance and a part of this board.
So Gwen and Rebecca, should we, with all of this, what do you need from us at this point? Where would you like to take this?
I think we have what we need at this point. We'll be able to kind of continue to track the current state of the environment, our delay in data, and see if we can do this survey at another point in a better space and have it look a little bit different to get some more meaningful results on it. Thank you.
Great work and really good discussion too. So, you know, I think it's important for us to all feel, I mean, this really is the roadmap. So, and it's our community. So I appreciate the investment of added time. Okay, so next we have the 2022 CCO performance metrics, followed by our Q4 2021 performance metrics. Trisha, I'm going to turn it over to you.
Sounds great. Thanks so much. I just want to set the stage a little bit by going back over some of the reasons why we're looking at this new version of performance metrics again. So our intention here is to help provide the board with visibility in key areas of the CCO. This is actually stipulated in the JMA, the Joint Management Agreement, that the board's responsibility is to collaborate with Pacific Source and also monitor the performance of the CCO. So that's the real reason behind you know, both doing this work and ensuring that we are allowing you the space to have insight into key work that we're doing. Similar to last year, this document was organized into 4 categories, but what we did that's significantly different, and you will see as we shift into last year's review, is we decreased from 19 metrics to 8 metrics. The reason for that is throughout last year, we became aware that several of the metrics were process metrics. So once they were met, they were no longer under discussion. Other metrics are really better to be held in other health council spaces for deeper conversations. And I think what's also brings some value to this place in these metrics is that these are the same, the CCO directors crafted this with subject matter experts in the organization, and they're the same across all 4 CCOs. So I think that that brings value as well in our ability to use the internal subject matter experts to really do a deep dive in this space. Let me just double check. Yeah, so again, most of the metrics will be performance-based except for 2. And again, when we're done, once the board approves this process, I will turn this into a document that again will be a yellow, green, red Is that the order of the stoplights? I've only been driving for 30 years. Don't tell my dad, who was a driver's ed instructor, that I said that. So, all right, so we'll turn it into that. So we reviewed this in pretty decent detail last time around, so we're not going to do that, but I'm going to hopefully bring the highlight the 3 items that were under discussion last time. So if you go down to the bottom left quadrant, the CCO 2.0 requirements, the second metric in that space is in partnership with the Oregon Healthcare Interpreter Association to train and certify up to 60 cultural and linguistically responsive healthcare interpreters across the PCS contracted medical interpreter vendors. So there was some question there about how much Central Oregon would benefit from this space. After we met, I reached out to the subject matter expert in this space, and here is their response. Our vendors serve and provide across all CCO regions. This is done through a mix of service modalities and includes phone, video, and in-person. As our contracts cover all regions, all CCOs will benefit from this. So I think that's important, but they sort of took the answer to the next level, which I think could potentially be helpful too. And then I'll pause and open up for any questions. The next level is there was part of, in 2020, there was an institution of some new invoicing processes to help gain some more detailed information on how and where these services are provided. So for example, if the service person is in Salem and providing care to somebody in Central Oregon, that would now be documented and through what means, so telehealth or telephonic interpretation. So we haven't been able to really gain meaningful information in that space because, as you can imagine, most of the interpreter services that have been utilized have been telehealth or phone. So pulling that data isn't that insightful at this time. However, we are gaining data in these places, and we can look back, hopefully in 2022 and 2023, and start to see where more of this crossover work is done. So the foundation is laid for that work and that deeper dive. So I will pause there and see if there's any other questions or concerns around that metric. Okay.
Not
Trish,
seeing
this is-
hands up. Oh, Brad.
Oh,
Go
sorry.
ahead.
This is Brad, sorry. Yeah, I just want to emphasize again that, I heard what you said and I appreciate you getting that feedback, but I'm still concerned that we're going to end up with, disparities in terms of who's receiving in-person interpretation and who's receiving interpretation through telephone and other means that are pretty much across the board less effective. So it's just a concern that I don't want to lose sight of, and make sure that, Central Oregon doesn't end up with 90% of those 60 or whatever number it is, a high percentage being through the telephone, whereas the Valley is getting people in person, much higher percentage of in-person interpreters, that kind of geographic disparity.
Mm-hmm.
And I would add to what Brad's saying as someone who at one time could speak sufficient Spanish, but never fluent Spanish, trying to make a phone call and manage a conversation in a language that you're not entirely fluent with. You just lose so much between a virtual and a live setting that you just lose so much information. It's stunning. So.
Yeah, you for sure lose a lot of the culturally responsive service that is provided in that space. I think you both know I come also from in-clinic space, and I know exactly what you're speaking of. And I wonder if there isn't, as we train these 60 new and certify, which is the harder component of that, maybe there's an opportunity next level, so this is next year's, or the data we will review over this year, but culturally and linguistically responsive language services is something that we will continue to work on, and potentially those will be sort of the next level steps that I think we can look to monitor moving forward. So I appreciate that. Thank you. We'll keep that on on the radar, and hopefully get much closer to doing a lot more in person over the next year or two. Well, let's cover the next metric. The next two should be pretty easy. They're both under operations. We just changed a little bit of language in both metrics. So the first metric reads under operations, closely monitor annual external quality review activities and address any health services advisory group OHA inquiries according to compliance standards. So what that replaced is inquiry. That's not going to be my word today. Inquiries in a timely manner. So we shifted that to meet compliance standards. So I hope, that was definitely the intent of our language there. So does anyone have any questions on that before we drop down to the last metric? Okay. So the last metric, we changed a single word. So it was meet. The way it reads now is meet resolution time of 30 days or less in 100% of appeals and grievances received. The word that we replaced, and again, our intent was resolution, was response time, but it drastically changes the way that reads. So I think the conversation in that space was really valuable for all of the CCOs. So does anyone have any questions on that? Okay, does anyone have any outstanding questions that either Leslie or Aaron or I could be of assistance before this moves to a vote?
Everyone's awful quiet.
It's exciting stuff.
Yes. Okay. Unless there's additional information that we need or discussion that we want to have, I welcome a motion for accepting the performance metrics. And I believe that we would have two. Would we have the for the CCO 2022? Is it just the Q4, Donna, or is it both? Or Tricia?
My understanding is the vote is on the new proposed metrics and reporting.
Very good.
That's correct. Just
Okay.
for 2022.
Very good. I wasn't sure if we were voting to receive the formality of receiving your update, but okay. So any other questions, edits? Appreciative of the narrowing of the focus in those metrics, which is really important too.
I'm happy to so move.
Thank
I'll
you, Paul.
second.
Thank you, Linda. Any further discussion? Okay, and as last time, anyone
I do have a
opposed?
question.
Oh, please, yes.
I just, what Brad was saying about those 60. Are those 60 going to be in Central Oregon? I just want to confirm that. Or is that for a bigger area?
Yeah, I'd be happy to jump in there. Our vendors serve across all CCO regions, so we will train vendors that are in all of the different locations that we serve. And they serve through a mix of service modalities that includes phone, video, and in-person. So 2 out of those 3 times they're able to connect with somebody who is not in their direct location. So hopefully the training, and again, the hardest part of that lift is the certifying in that space, so that we can get more culturally and linguistically care interpreters.
So is the
available.
certification through the state? I mean, is it a license that they're going to actually get through the state of Oregon to be certified?
That's my understanding how that works. Leslie or Aaron?
Yes, that's correct. The Oregon Health Authority manages that certified and qualification standards process.
Yeah, Patty, it's a relatively rigorous standard. So just being able to translate doesn't get you there. There's classes and a test you have to pass. And which makes sense, trying to translate medical terminology appropriately is a challenge. But yeah, it's a deal.
I mean, I just wanted to make sure that yeah, they weren't going to the lowest level. I think it's really important. I know my husband could do medical Spanish because he did treat a lot of people that spoke Spanish. So I know and I know we're always trying to find people that are bilingual, but I don't believe I've ever heard that they had to be certified. So perhaps in some cases they are. Thank you.
Great discussion. Anything else before we go forward with the vote? Okay. Anyone opposed to moving forward? Okay. And that is stating that we are approving the 2022 CCO performance metrics. Excellent. Thank you, Tricia. Really appreciate your hard work on that and support for us as well. And let's go on now to legislative inquiries. So Donna, I'm going to turn it over to you.
I think I have part two.
Tricia has part two.
I'm sorry, Tricia. Look at me just blaze through the agenda. Okay, my apologies.
Clearly you have read this and have no questions. So, but for anyone perhaps who has not read this thoroughly yet, I'd be happy to do a walkthrough and no problem, Tammy. So this is the format that you all just decided to not move forward. So this is a lot of metrics. I did condense it down, but it's still 4 pages. My hope here is I'm not going to read this through. It's there in your packet. I do have 7 highlights to pull out. And without being able to see all of this, we'd probably need to be in a conference room with an 85-inch television, which is a real thing if you've been to Costco. Go ahead, Rick, please feel free to jump in.
So just, I looked up, I'm on performance improvement plans number 3, and the movement of OHA wanting to change from social determinants of health PIP to the SUD waiver plan. And I looked in my documents and I started advocating for this waiver in 2009 and have been on the review committee ever since, and have gone through probably 4 generations of OHA staff, the current, and each time they become less competent. And so the current implementation staff are all new folks who have no idea what they're doing. And so just keep me in the loop on this because I'm involved at the state level at another level and have been for many years. Thank you.
Yeah, absolutely. Just because it isn't something that is no longer being reported in this space, as this work is continuing and will find its way in different committees, if you will. But yes, Rick, I'm happy to continue to keep you informed in that space. And I guess I'm sorry for generations of work there, but resilience, that's what I'm saying there. So we're going to go through about 7 highlights. Without being able to see this on a very large screen, all of the metrics are green. So we really have a lot of celebrating to do in this space of this incredibly difficult year. I want to start right out of the gate with the quality incentive measures. This has been our roller coaster metric this year. We started in yellow, we went to red, we went to yellow, and now it's in green. It's in green so much due to the rebasing of the metrics that happened. Without that, we would still be in one of those other colors. So thankfully we did meet 9 of the 11. That means we qualify for full payout in that space. But the unique addition in QIMS this year is that the emergency EOT metric, I can't believe I'm not gonna, feel free to jump in, Leslie, but it's the COVID metric. Central Oregon missed 2 areas in that space, the 12 to 15-year-olds and a couple of the race and ethnicity categories, which means we'll qualify for a partial payout in that space. Thank you, Leslie. That's emergency outcome tracking measure. And so although we do meet some of the challenge pool metrics, so we feel confident we're going to shake out in the wash somewhere between 90 and 100%. I hope to have that information to you soon. So the good news is we did elevate to green, and the metrics continue to follow a guide path for this year, for 2022. So we remain hopeful in that space. And maybe what we'll do is I'll go through the 7 highlights, and then if anything we don't cover, we can kind of hop back to in the questions, if that sounds like an approach that's okay. Then let's go to the next page. Great. I think it's worth noting here at the very top on the left, the value-based payments. We are currently at 59% are in a value-based payment arrangement, which is tremendously exciting for Central Oregon. The goal we think for next year is 30. Well, we don't have the goal. Hang on, I think I'm getting a little ahead of myself. We do not have the goal, but we're set up very well in this region with a 59% currently in that category. There were some gifts as well as in 2020 that we were allowed to be at a 2B versus a 2C. And I know this gets complicated when you don't work in this space a lot. And I do want to circle back a little bit to a question Brad had at the last meeting. And that he had some questions about how the value-based model works and is it successful in Central Oregon. And I want to share that I reached out to a couple of experts internally, and no other region outside of Central Oregon has a hospital and IPA CMHPs sharing risk in the same contract. So it creates a space where integration and collaboration is built into the process, and it's been successful in that we have met very successfully the metrics in those spaces. So I did want to circle back to that, Brad, but I wanted to add it in a space here where that metric was being discussed. So before I move on there, are there any questions? And I would like to offer, I guess, real quick, if the board would like to do a deeper dive into value-based payments, Peter McGarry would be happy to come to this space and talk more details about how that works. Oh yeah, Rebecca's also making an offer.
I think that would be great.
Yeah, I just offered that we could also have the subject matter experts from OHA, in addition to your Pacific Source internal leadership around value-based payments, come and talk with the board.
Great. How about if Rebecca and I take it offline, and then we'll bring it to Tammy. We'll bring that to you and Donna for future meetings.
Yes, I would just turn it to the board really quickly. Is that something that we would all support? I know for myself, I can always use the review and always learn something new. So, okay, I'm seeing some thumbs up and heads nodding. Wonderful. Yes, please. So we will work offline and bring that back to the board. Thank you.
Yeah, you're welcome. Next, I'd like to discuss, so if you go 3 down under value-based payments, you'll see develop a new VBP, a value-based payment in maternity care for 2021. So this is something, again, if you could see all the quarters throughout the year that had been, the notes were we'll negotiate with partners, we'll negotiate with partners, we'll negotiate with partners. And I'm happy to announce that in 2022, the shared risk arrangement between St. Charles, COIPA, Mosaic, CMHPs, and Pacific Source will include a hospital metric for prenatal and postpartum care, which will match the OHA target. We don't have a target for that yet, but our experts say it's estimated at 76.7. So that has been completed, and that work gets done in a separate metric committee that does the work for the shared risk arrangement in establishing those metrics. Anything there in that space? Let's jump down to share, because it's always fun to talk about money that we moved into the community and the success we saw so quickly. So the Share Initiative funding was $58,000 that was presented to Fuse to purchase supplies and put together landlord engagement and retention packets. As part of that gift, they also were able to grow their mitigation fund by $25,000. And it really just, a mitigation fund is intended to give landlords some ease of mind that should there be damage or loss of rent, that there is income in a bucket waiting there for their mitigation should they need it. Now here's the great part. Prior to the intervention, it was about 30% of the emergency housing vouchers were utilized. Immediately after, you could see the gift was made in December 2021, it went to 40%, or 38 of the 94 vouchers received were used successfully in a lease or rental pool. So I think it's pretty exciting when you get to see a nice jump like that. And the goal in our RIP is to get that to 50%. So, you know, we were in a space to help make that difference and increase by 10% so quickly. And hopefully, as that work continues, you know, it'll continue to grow. Does anyone have any questions about the SHARE initiative funding? If not, let's pop down to required plans. I just want to share 3 down and under the workforce development plans. Workforce development, yes, 3 down. Pacific Source awarded 15 Community Health Excellent Awards. One of those awards went to a business here in Central Oregon, and it went to Mosaic Medical. And I just wanted to share that they were provided a grant for expanding colorectal cancer screening throughout culturally and linguistically appropriate outreach. So I think that's definitely worth highlighting, and we look forward to hearing more about the results of that grant. Let's scroll down to financial stability. Just a little bit lower. Oh, perfect. I just want to highlight the 30-day hospital readmission, because at one point that had triggered yellow throughout the year. In Q2, it was 11.2%. So it's nice to see that readmission has decreased to 6%. And again, both of those metrics are inverse metrics, so the lower the better. And I'd be happy to move on to the next page, which continues under financial stability. So again, the financial stability at the top of the page, meeting or beating the CCO budget, was yellow last month. And it really was yellow to flag the awareness that the JMA shared savings was estimated to be a recapture. You see here by the end of November, that recapture was 3.7 million. It did grow to an estimated 4.1 million. That again, I just want to give kudos to the great leaders in our organization for waiving that. So we are again back in the green thanks to that waiving of that performance. And on that note, I don't have anything else specifically to call out unless anyone has any questions for Leslie, Aaron, or I.
Linda, go ahead.
Yes, backing up to the prior page where we had hospital ER readmits or hospital readmissions, is that measured against all readmissions or just readmissions for OHP clients?
OHP clients within a 30-day of readmission is the metric.
Okay.
As I understand. Feel free to jump in again, Leslie. And I'm going with yes then.
Yes, sorry.
Great. No worries.
Okay, any other questions for Trisha? Wonderful job. And it's good to end on a high note also of that recapture gift, and looking forward to the 2022 year as well.
Thank you.
So let's go forward with Donna next.
Thank you. And Tricia, I just wanted to say, and this is kind of seems to be the theme of the day from Pacific Source Community Solutions, is that the newbie gets to report really good stuff. And that usually isn't how it goes. Usually like, oh my gosh, I got to report this and it's awful. So, hey, good job. I just wanted to really very briefly actually ask the board if, and this may not be where you live, and if that's the case, that's fine, but I've spent a considerable amount of time the last couple of weeks on OLIS, on the legislative calls. There's a couple of bills that we're following, and I think that you'll all recall that as a matter of course, the Health Council, I don't want to say partners up, but certainly works in conjunction with Pacific Source and Rick Blackwell to see what bills they are tracking and whether or not the Health Council would appropriately have an opportunity for testimony or written testimony, whatever the case may be. After last year's experience with Senate Bill 741, it's kind of fun to help others out. I understand how it is now. But I really wanted to ask the board whether there was any specific House bills or Senate bills that they would appreciate just another set of eyes on, or even just being on the call. And any of you that have done anything, of course, this is short session, so it's like a whirlwind. Sometimes just being on the call is enough to really boost support, or maybe not so much support. So again, it may not be something that you're tracking specifically, where I would welcome someone in your organization to reach out to me and share. Again, it's short session, so it is fast and furious right now, but I just kind of wanted to open that up to the board. So that was the only reason for my agenda item, Madam Chair.
Donna, this is not actually a health bill, but it is a health bill. It's Senate Bill 1573 that Senator Knopp is working on. It's to do thinning in our in 25 counties actually, and instead of having our forests burn up, it's say we need to do thinning and keep them healthier and eliminate a lot of the fire dangers that we have. So that would be a bill that it's a stretch, but it truly is a health issue when we have smoke and I was hearing from someone complaining today because there's a prescribed burn and they're like, oh my gosh, it's the most beautiful day ever. And I go, well, do we want a little fire today or a big fire in August? So anyway, you might think of that one. It would be appreciated.
Thank you, Patty.
Any other bills that folks have top of mind that they're tracking closely that Donna should be aware of as well?
Donna, I'll look on our list from our health department and see if there's some other numbers I can send you, but that's just one that's outside that box.
Great, appreciate it. Hey, and feel free after the meeting to send me anything that you'd like, folks. Thanks, Tammy.
You bet. I think Brad's going to jump in.
I'm not sure. I mean, it's definitely social determinants of health related, but the farm worker overtime pay, which we keep trying to pass in Oregon and never seems to pass.
What's the number on that one, Brad?
I don't have that handy.
Okay, I'll look it up.
Apologize, but that's a pretty grave injustice, I think, not to pay our farm workers overtime for when they work overtime.
There's some pretty interesting ones coming through short session, so great.
Okay, Donna, do you have what you need? Okay.
Yes, I do.
Excellent. So next we have the RIP report. I'll turn it over to the team. Who's taking the lead?
That would be me.
Okay. Michaela, go right ahead.
Right. All right. So the project managers and I are going to give an update on the RIP work groups. We'll provide more details on their specific implementation activities. And at the end, we'd like to hear what information is most valuable to you to help us plan our future RIP work group updates. Sorry for all the dinging. Okay. All right, so first we'll dive into our community investments. So on this slide, you can see the total collective investments and investments to date of each work group. In total, the work groups have invested a collective $3.8 million of their 5-year $12 million budget. Continuing down, you'll see the investments broken down by each work group as of the end of January. So please keep in mind that these numbers do not include the open requests for proposals or projects in the work. And as you know, each work group was provided $2 million as a tool to use to achieve their future state measures. These funds must be used by the end of 2024, and each work group is committed to investing about $500,000 yearly. Looking at the year to date for 2022 on the right-hand side of the slide, as of January, they are already well on their way to meeting their yearly collective investment goal. I'm going to pass it on to Renee to go over the workgroup implementation activities.
Thanks, Michaela. So in October, we gave you a high-level overview of what the RIP work groups had been up to in 2021. And today we'd like to provide you with more details about some of the projects that the work groups have funded in the past year. Next slide, please. So the Promote Enhanced Physical Health Across Communities work group at the end of 2021 had funded 5 projects aimed at increasing youth fruit and veggie consumption and physical activity. Here are some of the highlights from the applications. Creciendo Girasoles, Growing Sunflowers by High Desert ESD, will provide scholarships for students to participate in after-school sports programs by removing financial barriers for migrant families. And this is so that youth of all ages will have access to athletic enrichment activities that have only been available to them in a very limited capacity in the past. RX to Move by Mosaic Medical is a program where pediatric providers refer children ages 6 to 18 in need of increased physical activity to the community health worker for assistance in identifying the child's needs. And this includes activities that the child would like to access, any barriers to activities, any resources that would support the child's participation in regular physical activity. Fruits and Vegetables for Kids by The Giving Plate has 2 programs for youth. Kids Corner empowers youth to shop at their own special store where they can get their own food to supplement the food their family gets in the food box program. And the second program, Backpacks for Bend, serves K-12 students in the Bend Lapine School District who are identified by fan advocates and teachers as children who would experience a weekend of hunger. And Let's Be Active and Eat More Fruits and Veggies by OSU Extension will utilize nutrition education touchpoints that will increase opportunities for youth to experience and learn, including recipe tastings, mini lessons, cooking classes, and outdoor physical activity. And finally, Learning Good Health Habits Early in Life by Jefferson County Public Health will focus on promoting knowledge through health education and community outreach events, and increasing physical activity and maintaining healthy weight, and referrals to access food pantry and wellness services. And the Physical Health Work Group is also in the process of reviewing applications for funding aimed at increasing integration between medical and dental providers. And they are about to release an RFP to create regional coordination aimed at increasing collaboration between agencies to address sexually transmitted infections. Next slide, please. The Stable Housing and Supports Work Group funded 3 projects in 2021 and are now working on strategies to increase advocacy and education about housing and homelessness in the region. We have received progress reports from 2 of the projects that were funded so far. The first one is for the Regional Housing Council, and the concept for the Regional Housing Council has been met with approval. Because it's a pilot project in the state, there are frequently follow-up questions from elected officials about the role of the Regional Housing Council and specific duties of those serving on the Regional Housing Council. But these questions are coming from a place of excitement and opportunity rather than skepticism and doubt. One of the costs of the COVID-19 pandemic has been a marked decrease in jurisdictions' capacity for regional collaboration. So there was some concern that it may be too soon to embark upon the formation of a region-wide collaborative body. However, there's an appetite in the region for such a partnership. And the second progress report we received is for FUSE, which stands for Frequent Users System Engagement. And they were thrilled to report that they exceeded expectations in this tough housing market by supporting 7 chronically homeless individuals into permanent, affordable, supportive housing. And they're using federal funding to subsidize rent for participants for as long as they need it. And they have partnered with REACH to provide regular housing retention case management services. So far, participants have 100% remained successful in housing and anecdotally reported positive changes in their health and well-being. And I'll turn it back to Michaela.
Thanks. The Substance and Alcohol Misuse Prevention Treatment Work Group has contracted with the University of Wyoming and Sunshine Consulting to comprehensively assess key drivers of binge drinking among 18 to 34-year-olds. And this will include using existing data and focus groups. Then the consultant will provide recommendations based on analysis of the data with specific recommendations regarding options for reducing health disparities among key subpopulations. And this project will wrap up in the fall of 2022. They are also partnering with the Physical Health RIP Work Group to implement Healthy Retail, which is redesigning stores to make healthy choice the easiest choice. And they're considering a media campaign to reduce vaping. They're also in the middle of reviewing applications to stabilize peer support services with a 2-part project. The first is to fund 5 clinics and community organizations to sustain peer services in the short term. And the second is to hire a consultant to work with the funded organizations to increase their financial sustainability, as well as work with the work group to address larger system level issues. Specifically, the consultant will create peer service sustainability plans in collaboration with the funded organizations, provide recommendations to bridge regional peer services needs to statewide policy change, and determine and gather data from funded organizations to inform advocacy and policy needs. The Address Poverty and Enhance Self-Sufficiency Work Group invested in 5 programs and initiatives to increase high school graduation rates among students who are economically disadvantaged. A couple project highlights are Crook County School District's Graduation Equity Improvement Project. This project seeks to pilot an early intervention graduate coaching model to provide resources and support to freshmen and sophomores who show early warning signs of potentially not graduating. Their early success shows 85% of their sophomores and 93% of their freshmen are on track to graduate. And they've hired a graduation coach to meet with the students and has developed an individualized recovery plan for every student who is off track. The second highlight is that OSU Open Campus is impacting graduation rates through student and family engagement project. And this is a partnership between Juntos and OSU Open Campus. It aims to address low high school graduation rates, focusing on disparities for Latinx, rural, and low-income students. This project provides culturally relevant programming to help students and families navigate the school systems, pre-college programming, career exploration, extracurricular experiences, and mentoring by current college students. The current success is that they've recruited and trained 4 diverse mentors that are working with the students and providing graduation support and helping with post-secondary pursuits. Also, 7 youth and 2 adults from the Warm Springs community are able to visit Oregon State's campus in Corvallis through this program. The Address Poverty Work Group is also investing in urgent food insecurity needs in Central Oregon and coordinating with the regional CDC grant that addresses social determinants of health. And they are also reviewing an application to address barriers of families who are asset limited, income constrained, and employed, or ALICE for short. This project will conduct listening sessions to determine unique needs of different communities. The listening sessions will have an emphasis on housing and transportation costs, and the results will inform diverse approaches for each community to improve outcomes and meet the future state measure.
In the behavioral health increase access and coordination work group, they've initiated the project around developing a measure for timeliness and engagement. And this project is around identifying, modifying, or developing a metric to measure timely access and engagement between specialty behavioral health care and patients referred from primary care. The long-term intent is that this metric will be integrated and incorporated into health plan contracts so that the providers are incentivized and rewarded for their efforts to improve timely access and engagement. And this is scalable to the whole Central Oregon region. They're also have a request for proposal open to improve behavioral health workforce, and specifically in the rural areas of Central Oregon. And this is really about creating and supporting a community-driven initiative for workforce development. And it's intended to be a long-term pipeline development to infuse local learners into our areas. And then finally, they have also just finished drafting, and hopefully this RFP will be opening to the public in the next couple months, around standardizing behavioral health screening across providers throughout Central Oregon. So this is standardizing screening processes, once again, between primary care organizations and specialty behavioral health providers, so that clients are assured to receive the appropriate level of behavioral health care and follow-up access. It's also around developing clear guidelines and languages between different types of providers, so that all providers are empowered and confident in the referral and the level of care a client may need.
Gwen, it looks like Patty has a question.
Oh, thank you.
Yep.
Yes, it was actually for Michaela. Michaela, when you were talking about Crook County, is this a grant that was already funded? Because their graduation numbers just came out and they actually improved a lot. And I'm wondering, okay, was this something that we did before, or is it something that was just put into effect?
So this program was funded spring of 2021, and it's aimed at mentoring freshmen and sophomores.
Because their graduation numbers, I think, were really outstanding. I believe when I was noting it, that they went up like the most of our region for on the successful way up. So maybe they can even get higher, because Oregon's graduation numbers are down at the bottom. So
Yeah.
this is good. Yeah.
Keep it at 100.
Yeah, I know. They can go to 100. Thank you.
Thanks, Patty. Great question. In the next slide, Upstream Prevention Work Group, they have identified partners, and the work is underway to develop a regional measure of resilience and belonging. And this is a large multi-phase project that includes a lit review, identifying a measure, collaborating across the community to make sure it's culturally responsive, the data collection, the analysis, the synthesis, the sharing results, and then they're also taking on working to obtain additional funding so they can do a repeated measure in 2 to 3 years. A couple of groups working on kindergarten readiness and third grade reading funded a number of projects. A couple of the highlights are a couple of examples would be Juntos Aprendemos, which is a culturally and linguistically specific program that uses an evidence-based curriculum that invites Latino, Latina, and Latinx parents and their kids, young ages, 3 to 5, to work together on early literacy skills in Spanish for a long time, 2 to 3 years, before entering kindergarten. This funding allowed them to expand their program into the Madras communities. Another example is the Reach Out and Read program. And this works to improve early learning literacy by providing age-appropriate books and guidance to parents on how and why to read to young kids. With regards to improving intended pregnancy in the region, the work group just awarded funding to build on the 2019 Ask Anything campaign to promote planned pregnancy. And this is around strengthening and supporting access to reproductive health care services, especially prioritizing our neighbors who have been disproportionately impacted during the pandemic in receiving healthcare and services. And then finally, they also just awarded funding to support the Regional Childhood Immunization Quality Improvement Project. And this works at the system and clinic level to help address and remediate the impacts of COVID-19 on the childhood immunization rates, and is a region-wide position. So that next slide. So that's a robust update on what the work groups are doing, things that they're funding. Are there any questions about any of that content before we ask you a question? All right, Renee.
Gary has a question.
Oh, thank you. Sorry, I can't.
Yep. Nope, it's all right. Up, and Patty does too. So Gary, then Patty.
Great.
And sometimes I wonder if I should just speak up rather than raise my hand, but I guess it's worked. For all of the categories, there was outcome data or outcome highlights that were reported out for a couple of the investments. And I understand that some of these are just projects being initiated or they're in the RFP stage. And so obviously outcome information may not be readily available, and maybe it's just a suggestion for future report outs. It would be helpful to know what is the return on investment, how many are participating in, for example, some of the health activity investments. There's good data on what the spend is, but not so much on what the outcomes have been.
Absolutely. Thanks, Gary. And that's going to be our next question, is what all would be helpful for you as we start getting impacted. So thanks for kicking that off. Patty, go ahead. What was your question?
Okay, so mine was about Friends of the Children, because that is one of my very favorite charities. I bought like 25 books for the program this year for their Christmas, or last Christmas, for their, for the mentors to give to the kids. But is that area, I believe I heard that COHC was funding, like adding 15 more kids to that program. Is that the right thing? Is that the right story? Because I know before there was like $6 million given to the program, but it really wasn't given locally. So I just want to make sure that I heard the news right.
We can, depending on which, we can definitely get the information. I know they have been funded significantly through the Central Oregon Health Council and multiple times throughout the years. And it's usually the local chapter that that's funded.
Okay, good.
More details.
Because it was a bit, everyone thought they got millions of dollars, and they're like, no, we didn't get that money. It's going to go all over the country. So anyway, they are an amazing program. Thank you.
All right, Renee, any other questions, or I'm going to hand it over to Renee.
Hey, Gwen.
Take it away, Renee. Oh, Brad, sorry, go right ahead.
Sorry, I just want to ask, one group that you didn't report on was CODI, the Central Oregon Diversity, Equity, Inclusion Group. Could you just give us a little highlight on what that group has accomplished and how that's impacting all of the groups?
Great question, Brad. I'm going to pull on everybody to help answer. So CODI is not included in this report because they are not they're not a priority area in and of themselves with the Regional Health Improvement Plan. They are a committee. And so their role is to help infuse diversity, equity, and inclusion throughout the RIP, other committees, and into the community, into the other committees, and into the community. In the last board packet, we did include, when y'all approved the statement, we did include their action plan, and we're happy to put a link up to that, because it's a Google document and it's accessible from the website now, from COHC website. So if somebody could grab that, we're happy to share that. There's a one-pager and a little bit more in-depth version of that. Their priority areas have been identified through conversation with them, as well as you, the board members, around learning and education, data, and policy. And so those are their focus areas. And we can provide the links for the more detailed outlook.
And as you said, there's the idea is to kind of infuse the values of Cody across all the work groups. Is there anything you can report on that? Like how is that being successful? Pretty successful? Are there some examples?
Yeah, I think some of the examples that you see are how the RFPs are being written right now by the work groups. There's been a very conscious effort in the work group member, and this is, community members from your organizations and others, consciously considering who are the most impacted by these issues, how do we involve them and partner with those most impacted in designing the solution. If we're contracting out to a different entity to actually do this work, how do they do that work and what's their experience with it? We also see it as many of the partners are reviewing the grant applications, asking those questions, and starting to consider some of the more nuances of even how the application, how the applicant answers the questions, and starting to take a look at more of the nuance and not just the writing quality, if you will, but what the project is doing and all the different factors that can impact what it appears like to us as a reader. So it's a broader conversation when they're assessing grants. The mini grant process a couple of years ago was rewritten to really focus on capacity building, so smaller organizations, as well as development of diversity, equity, inclusion supports. So those are just a few ways that come to the top that I think you would see woven throughout the work group work. And I'd open it up to Renee and Michaela if there's anything else you'd want to add.
I think you did a good job, Gwen. Yeah, thanks. Are there any other questions? All right, so our question for you, we're scheduled to provide you with RIP work group updates every 4 months. So the next one will be in June. We want to know what's valuable to you. For example, would you prefer budget updates, high-level overviews of the RIP work, details about funded projects, or would you like to hear from some of our work group partners and grantees, or some combination of all of that? But we want to know what's most valuable for us to bring.
I would weigh in here if I could, that first of all, I always enjoy hearing about what's going on, how the money has been spent, what's being used, and as Gary said, perhaps most importantly, what are the outcomes, what's actually happened. And I wonder if indeed the plan is to have you come to us every 4 months, 3 times a year. One of them you could focus on the budget, another you could focus on outcomes, and another you could focus on perhaps some stories related to it, because I think all of those are valuable. I guess that would be my suggestion.
I see Linda and then Divya.
Yes, I know we haven't originally thought about this, but if there's a way that when you present the grants, you can maybe create them by categorizing which ones really are direct service provision versus which grants are more towards system redesign. As I think when we look at what are the incentives that cause us to have health disparities, if we're just increasing and catching up on services, but we're not changing the system, it's just a question for the council, is that where we would want our dollars to be going?
Thank you for that, Linda. Divya, go right ahead.
Yeah, I think for me, I know this is gonna possibly sound really strange. I'm less concerned about the budget at this point for RIP. I just feel like there's a lot of money in that space. And so, yes, that's important. And I trust that that's being monitored. And I'd love to have an update on that once a year. I'm a lot more concerned about actual outcomes and metrics. And I think what I would love to, on a quarterly basis, get a better understanding, again, ongoing understanding of what are quarterly metrics that we are monitoring. And how do we know any of this is, so how just that like outcome, it's more than an outcome, because an outcome can be long-term. It's more just gradual metrics that we are tracking. And if we are meeting those metrics, we're going to achieve the outcome.
And I think you're speaking what my mind is trying to come up with in terms of, coalescing it down. So it's a connection between what it is that we're monitoring and not necessarily the individual investments, but collectively, how are we moving the dial? Is that what you're also saying, Divya? Okay, very good. You were saying it better than I can, but I think it's wonderful to know if we have a partner who's really struggling, because sometimes they might make an ask and it turns out that once they start getting into the project, it just, for whatever reason, isn't quite going, quite right. But I think collectively, how are those investments moving us forward or not? And maybe also, where are we not making investments that we should be? And there's an area that's has a wee bit of a glaring gap.
So
yeah,
Rebecca put in, that every awardee has actually fairly rigorous reporting requirements. So you can dig into each individual entity, and that's all tracked. I think Divya is more asking about, is this whole initiative having an impact? And I think we probably need to think through how to measure that. And then I would just say, because I think maybe Brad's in a committee, but I'm on two of these. Some of the deliberation process is fairly slow. So, the behavioral health folks, we like to process a lot. Housing likes to spend a lot. So housing spent right away and we're still processing. So I would say that I don't think either of the behavioral health work groups is at a stage where that impact could be felt, but it should be showing within the next year or two. So it's a longer process. So how we conceptualize that and get to where Divya wants to get to, I think we need to think through more carefully.
Thank you, Rick. I was going to mention that this kind of goes back to, where we started with Rebecca and Gwen speaking to the survey, and Megan, to your point. We clearly are not the only moving party in the metrics that have been chosen for the RIP by this body in the community. And what we have done is we've invested heavily in data and a digital platform so that we wouldn't have to rely on pulling all of these data reports from different places. And not solely because of the pandemic, but to a great degree, the pandemic has wreaked havoc on our data points. So what we would love to be able to do, what I would love to be able to do, would say, from today, for 45 days, I'm going to monitor that data point for you, and I'm going to come back and say it did X or Y. But we are not the sole contributor to the benefit or the deterrence from that particular metric. So we're looking for a trajectory here of whether there's been differences made. But again, and you all know this, the pressures on the community and on the health ecosystem have been something that's just been unprecedented. So whether or not we might be making grand strides in our little space, but you won't see it on any type of data report. So to Rebecca's point, we do have objectives, SMART goals and objectives on every single grant that is awarded. And of course, it's awarded by the community. It's not awarded by your COHC staff. So we will continue to try to bring back what it is you're looking for. I'm a numbers girl, so I know what it is you're looking for. We want to see that what we've invested in is actually making a difference. But whether we can see in one nice, neat accounting kind of metric, I don't know that we can do that. So anyway, we will continue to try.
So I think Donna, I think that's great to point out. And I don't think any of us think, or I mean, I certainly don't think that RIP Group is the sole owner of the betterment and outcomes of the, I mean, I recognize RIP is another, but a pretty, hopefully, powerful vehicle, just because there is more leeway into where dollars can be spent into what type of overcoming certain barriers. I find RIP groups to be, the overarching group itself and what it's supposed to do to be really the most closely tied to health outcomes. And so in that space, if RIP Group is the one that out of the RIP monitoring, if that's where it sits, how are we doing along that trajectory? And that's not to say it's because RIP, each of the things hasn't done their part or whatever, but just overall through all these grants and stuff and through everything that the clinics are doing, all that stuff, how are we moving the dial in those? What are those metrics? And I'm not talking whims, and I'm not, it's how are we measuring that, and how are we moving along those metrics? I think would actually make, hopefully, the RIP work feel really kind of good and along the lines of, yeah, progress is happening, and how much do we attribute to this one program versus this program versus that program? That's much harder to do. But I'm talking the bigger RIP bucket, and what are the metrics in those?
Any feedback on that?
I have some additional feedback. It's sort of to take what Divya said and take it a little further. If we notice that we're not moving a huge metric like unintended pregnancy or increasing resilience in the community, there's no other body other than this one, I think, that really has the responsibility or maybe the authority or the discretion to take a step back and to say, if what we're doing isn't moving the needle, if you will, then what does that mean? And what should we be doing? What questions should we be asking differently? Because ultimately it's about improving the health of our community. And if on one or more measures with all the effort, if we find that there's been no movement, somewhere there needs to be a conversation with our partners and the council about, so what does that mean and how do we interpret that?
Great points. So Donna and team, is this sort of coalescing into something that we might be able to wrangle and bring back?
And also, do you regret that you asked that question of us?
Scratch that slide. Oh, I'm sorry.
It's probably the most critical question. So it's really an important one. So
Yeah, absolutely. Appreciate all the points being made.
All right. So team, is there more? How do we do? Okay. I just want to give a shout out. Thank you for the deeper dive today into the metrics and into the projects themselves. And I love that you tag team and really just frame it up together. I think it also just helps give a showing of our talented and amazing staff too. So thank you for your dedication to that work. So next on the agenda, we have the recruitment committee update. And if I'm looking at it correctly, I believe that's next. So Justin, unfortunately, is not with us today. And so Megan and Divya, I will take a stab at it. As a reminder, our committee for the recruitment is Divya, Megan, Justin, Dan, but right now sitting in for Dan is Lindsay Hopper. We also have Linda. And so Linda, also keep me honest. And then myself, Iman, Justin, and myself. And so we have started the interview process. Thank you to Specialized, also known as Express in my mind, who Karen Turner has been taking us through this process. She had over 300 applicants for the position, which tells us that there's deep interest and incredibly talented individuals applying for the position. And it was really difficult to narrow that down. And the candidates that were brought forward resulted in 3. And that, as you might imagine, was incredibly difficult. And so we have started that process. The outcome of that process will be finished next week. We are having 2 different, broke up into 2 different committees to do the interviews. And that outcome will determine what our next steps are. So wanted to just give you an update on how that process is going. It, as you know, is a bittersweet one for us. And really excited to see the level of interest, the level of professionals that are coming forward and the talent, and wanted to provide that update to all of you. Anything that I missed, Divya, Megan, Linda, Donna?
You captured that beautifully.
All right. Okay, any questions from the group? All right. Linda's giving a thumbs up. Wonderful. Is there anything else for the good of the order that anyone wants to share? Okay. Well, if no one minds, I think we'll go ahead and adjourn a little early.